now. Um, so week 17, this week we've got two chapters to cover, 35 and 36 in your book. Those chapters are going to be talking about soft tissue injuries, burns, and then musculoskeletal injuries. So those are the things we're going to discuss this morning. And then that's the stuff that you will be working on in the lab this week. So as always, when you start a chapter in your book gives you a nice little A&P section at the beginning. They kind of get you familiarized with the body, what's going on. This chapter 35, exactly the same. We're talking about the skin here with the soft tissue injuries. So they give you a little breakdown of the skin, what's going on in there, all the layers, that sort of thing. So first of all, we'll talk about the purpose of the skin. What's the purpose of the skin?
To protect your body and regulate heat.
Okay. Regulates heat, body temperature. It provides the outermost layer of protection from infection and other things. And it regulates fluid balance. So it has quite a few significant purposes. And so when we have injuries to soft tissue, it could be it could be impactful on the body. So soft tissue injuries, they put them in two categories. So if you want to think of these, the closed and open soft tissue injuries, that'll kind of get you started in the treatment mechanisms and what we'll be able to do with them. So the difference is if it's a closed injury, there's no break in the skin. If it's an open soft tissue injury, then there is an opening in the skin of some sort. So what you'll see differently is the open injuries are the ones that are most likely going to be bleeding. External bleeding, that's going to be the first thing most likely that we're going to have to deal with. So our mode of operation now is to stop bleeding as quickly as possible. So so this will be your first action if you have these open soft tissue injuries. So depending on what caused the injury, how extensive the opening is, that's probably going to dictate how much blood you're looking at, how much bleeding you're facing, and then the location will be determining how you'll go about it. You know, if it's on the extremities, direct pressure will help with stopping the bleeding. You have the option for tourniquets. If it's in the torso, abdomen, or chest region, you don't have the option for tourniquets anymore, but you still have direct pressure. Remember now that this stop the bleed deal, so we can pack these wounds to promote the stoppage of bleeding. So make sure if you have like Quick Clot or something on your trucks, if you have medics that have access to TXA, those types of things, that you're using those to get that bleeding stopped. The closed tissue, the closed injuries for soft tissue, this is going to be more in line with your blunt force traumas. These will be injuries that are more internal. What you may see is bruising, the contusions, the goose eggs, those types of things. You may see those on people, but you won't see external bleeding because there's no break in the skin. So these are the ones where you're going to be looking for suspecting internal injuries. And if we start to see the bruising and contusions, then we know that there's some degree of internal bleeding. But these are going to be much more difficult for us to manage because there's actually no wound care to do. So this is all going to be signs and symptoms. This is going to be monitor vital signs, trending for shock, and then if we see that, then we need to treat these folks for shock. So and then transport destinations may change or be more significant for the patient in the long term for their definitive care. So if they have extensive internal injuries, they may need some trauma surgery or something like that. So that may change our thought process about where we're taking them or how we're getting them there, depending on the situation. But those would be the things that we're going to look at. So most likely the open injuries, we're going to do bleeding control, we're going to do wound care, and then if it's significant enough, they still may end up in shock, which we'll be treating for. With the closed, there's no wound care because there's no open injuries. So it's all going to be management for shock in the closed injuries. So your book has a series of pictures throughout this chapter that give you some nice different injuries. So it should go great with your breakfast. But they've got one, if you're looking at 35-2 in your book, figure 35-2, that's a significant injury to the abdominal region. It's a huge contusion covering most of the lower abdominal region. So we would be thinking some significant type of blunt force trauma with a lot of internal bleeding there. And this would be your concern, is monitoring this patient for shock, but also trying to get them to a facility that's going to be able to go in there and explore and figure out what's bleeding and what they need to do to stop it. So they may can find that on ultrasound, but or CT, but most likely there's probably going to have to be some surgery involved to go in there and repair those vessels or organs if it's one of the organs that's bleeding. The next thing your book talks about is crush injuries. These are soft tissue injuries, or could be, and they could fall in either category, open or closed, depending on the crush and what's doing the crushing. What is our issue with crush injuries and managing that?
You've got the significant damage from a crush injury, like bone fragments and stuff, that can cause a lot of internal bleeding.
Okay. What is the crush doing as far as blood flow is concerned?
It could be constricting it.
Okay. So if there's interrupted blood flow, which means that the crush is stopping the flow from getting to whatever's being crushed. Remember, we talked about this in the discussion back in the medical section. We talked about rhabdomyolysis, and that's a a toxic breakdown of muscle, and it causes toxins to be in the blood system. When they're circulating through the blood system, they're causing lots of problems, which are going to result in electrolyte imbalance. It's probably going to lead to cardiac dysrhythmias, and in the extreme cases, renal failure. So, which is going to further cause cardiac dysrhythmias because of electrolyte imbalances. So, if we have crush injury people, and we're trying to, number one, people are going to be trying, usually fire departments going to be trying to remove what's crushing them and remove them from that situation. In the meantime, we can be doing our treatments of these folks, which is going to be treating them for shock, most likely in the beginning. But we have to do some things to treat them before that pressure is released. Because once that pressure is released and the blood starts circulating again, or is allowed to flow past that crush, some bad things are going to happen. So what are you guys thinking? Anything? Do you know what's going to happen when that blood flow is released and allowed to go?
It could have a clot.
I say it's
Okay.
probably going to kill the person.
Yeah, it's probably going to kill them. Most likely, it would. The issue is when and time is a factor here, because the longer that crush is in place, the more rhabdomyolysis that's taking place, the more toxins that are building up. And so you're going to need some extra help there. From a medic standpoint, these what they want to do is load these patients up with some sodium bicarb before that pressure is released, to kind of help neutralize those toxins. And then you've got to prepare for the shock that is going to ensue. So if it's a severe crush, we're expecting what Zach said, with muscle, bone fragments, bone crushing, muscle damage, vessel damage. And if there's blood vessel damage when we release it, then they're going to probably start bleeding internally or bleeding externally if it's an open injury. On the extremities, this is, we can deal with this on the extremities because we can put tourniquets on. If it's a crushed arm or crushed leg, or both legs, then we can apply tourniquets all the way up, which may help with the shock and the toxin release as the pressure comes off. But if it's a crushed pelvis or abdomen, chest areas type of thing, then we're not going to be able to do that. So this is probably where those people are going to, as soon as that pressure is released, like Brian said, they're probably going to start heading down toward the point of coding. If these patients are alert, able to talk while they're crushed, the chances are, if that crush, when that crush pressure is released, that's going to change significantly. So think about some things here if you have some time, big picture things. If these folks, if they've got some family that they could make a phone call to, or that could actually come to the scene, and you got some time while you're trying to figure out how to remove that crush, then that may be a good thing to do, because that may be the end for them. So just prepare for those things. At the A level, you're going to treat these folks for shock. If you can get some medics there, they're going to further treat them for the shock and the cardiac dysrhythmias that are going to come. But the end result is, if it's a severe crush that involves more than just the extremities, it's probably going to be a not a good outcome.
Hey, Cliff, can you let me in on my computer?
Nope. Sure.
I had to let it update while we were talking, so I
Oh,
came
that-
in on the telephone. Thank you.
All right. Let's see where I was. All right. So that's that for crushes. As you go through the pictures in your book, there's a crush injury to the hand where, it's got a couple mangled fingers there. They're going to show you some pictures, the abrasions. There's a degloving picture, which is quite gruesome. Amputations and different other injuries. They've got a gunshot wound to the abdomen, that sort of thing. So, again, remember how to handle the body parts if we're dealing with amputations. You want to preserve the amputated parts if at all possible. So put them in a plastic bag to keep them dry, but we also want to keep them cool, so ice or cold packs around them. But we don't want to you put them directly on it and cause a frostbite type of situation for that skin. Um, there's no guarantee that these amputated parts are going to get reattached or be able to be reattached, but we want to give them that option if at all possible, and they could do that, then fine. And if not, then it is what it is. So make sure you're doing that with the amputated parts. Remember dealing with penetrating injuries to the chest and abdomen. The preferred wound care is what?
Say that again.
For penetrating injuries to the chest and abdomen, what's our preferred wound care?
Occlusive dressing.
Occlusive dressings. So remember this, folks, from the neck to the waist, we need to be putting occlusive dressings if there's penetrating injury. So if these folks have been stabbed or shot or anything else that's penetrating in, we need to seal these things up. So just direct pressure with gauze doesn't do it. We need to get them sealed so that they can maintain that positive negative pressure ability for breathing. It's not really anything else that we're worried about it, but we're worried about that positive negative pressure from the diaphragm so that they can inhale and exhale and breathe. All right, so that's the reason. Make sure that you're getting that done, and that way they can maintain that. If there's no exit wounds, remember that whatever's in there is probably still in there. If it's a gunshot or some other object, if there's no exit wound, it's still in there. So be gentle with these folks. Try not to roll them or throw them or toss them or bounce them around, because that object could be in there moving around still, doing more damage. If there's an entry wound and an exit wound, then you have two to seal up. So make sure you seal up both of them, and you can get that going. There's a nice picture in your book on figure 35-9. There's an A and a B picture. This guy was stabbed in the shoulder right behind his neck. And they show the external picture, and then they show an x-ray picture. So if you don't have your book with you right now, you should look at these, give it a whirl, and see how those things are looking. This is one of those blades on a knife that's got that little notch on the end for similar to like cutting seat belts or skinning a deer or something. And that's in there. But just looking at the handle and what you can see of the knife, you would never know that. So one of the reasons why we don't take things out that are jammed in is because we can't see what's in there, where they are, and what we might damage on the way out. So that's why we let them do it at the hospital when they can use radiology to see and surgical procedures to get in there and free it without doing any more damage to vessels and nerves and things. So most impaled objects we're going to leave in place. You can shorten them if you need to on the external side, but we want to stabilize those in place and leave them. There's one area where we can take things out. Do you guys remember where that is? Impaled objects, where can you remove them?
I can't remember.
All right. Anybody else? Nobody? You can remove them from the cheek.
Oh.
So if you have an impaled object in the cheek and you want to remove that, you can. You don't have to, but you can. Essentially, there's nothing there that you're going to hurt or damage. So, but anywhere else, we're going to leave them in place. And they've got some more. They've got some more pictures in your book. Facial lacerations, neck injuries, lacerations, different things. All right. So again, bleeding control with your open soft tissue injuries. Direct pressure is how we do it. If direct pressure doesn't do it and we can apply a tourniquet, then we need to apply that tourniquet and get the bleeding stopped as quickly as possible. If it's an area where you cannot apply a tourniquet, then you need to start aggressively putting pressure on, packing the wound, using quick clot, those types of things, so that you can get that bleeding stopped. And then if it's a closed injury, you're going to assess the injury to figure out how extensive it is, manage the patient for shock, which is what you're going to be expecting, and then transporting to an appropriate facility to manage and give them some definitive care. Any questions about soft tissue injuries?
I'm good.
All right. Essentially, it's bleeding control. All right. Let's talk about burns then. How many different types of burns are there?
Three.
What are some of those different types of burns that people could get?
First degree, second degree, third degree, and electrical.
All right. What can cause, other than electrical, he said electrical, but what else can cause these burns?
Fire.
Okay. Fire. What?
The sun.
Sun, fire. Those are
Dry.
thermal
Dries.
ways.
Cooking.
Cooking,
Radiating heat.
radiation. Yes.
You can have cold burns.
Okay. So So we can have thermal burns from fires, from the sun, things that are radiating heat. We can have electrical burns. We can have chemical burns. So different chemicals that contact the skin can cause burns. Caustic chemicals, typically. Radiation can cause burns. So if you're dealing with high levels of radiation, if you're working around those types of jobs that use high levels of radiation, or weapons, or those types of things, you can get some radiation burns. So different areas, more than just the typically we know the burns are in the thermal region, so that's the one we're most familiar with. So the thermal thing, that's going to be fires, that's going to be heat from cooking, from the sun, that radiation from the sun that's causing sunburns and things like that. But there's some other areas that can cause these burns: electricity, chemicals, those types of things. So keep those in mind as we're going through here. Brian gave us the different levels. So we've got first, second, third degree. So that's going through the different layers of the skin. So first degree burns, pretty easy to deal with. That's going to hit the outer layer of the skin. It's going to be, you're probably going to see some redness of the skin, but the skin's going to stay intact. No blistering, no peeling. The way to deal with that is cool water. You can run cool water over that burned area. So if somebody touches a cooking thing that's too hot, it burns their fingers or hand. Cool water for 10 or 15 minutes should take care of it. Don't do any of those home remedies that you've heard about or that your grandmother did, although I'm not telling anybody's grandmother they're wrong. But we have to teach you not to do those things. So do not apply chewing tobacco. Do not put butter on it. No lotions or creams, that sort of thing. So cool water is the treatment for first degree burns. And they've got a picture in your book there. 35-21 is the figure, and there's a little first degree burn. It's kind of like a sunburn. So you'll see that 35-22 is going to give you a partial thickness burn. This is second degree. So in the second degree burns, this is where you're going to start to see probably some discoloration in the skin. You're going to see some blistering. You may see some skin starting to peel off, which is going to open up that outer layer of skin, and we're going to go down another layer. So more significant burn. What are the things that we're worried about with burns?
Infection.
Infection?
Dehydration.
Dehydration?
Are we talking about pre-hospital care?
Yes.
The skin getting so tight that it cuts circulation off and create
Yep.
compartmental syndrome.
Yep. That skin will tighten up. If it's like on the chest and abdomen, it could be a restricting factor for breathing. In other places, it may be a restricting factor for circulation. So as these burns get more and more severe, then what's left of the skin or the muscles may become so tight that that things can't move and circulate as they should. So we're not in the business of doing those surgical procedures, but they do have surgical procedures for cutting the skin to relieve that pressure. But that's outside of our realm here. So so we've got second degree partial thickness burns, again, blistering, maybe peeling of skin. This is where we start to worry about infection because the skin has now become compromised. So not an issue in first degree, but it is becoming an issue here in second degree. And then with the full thickness burns of third degree, we're definitely worried about infection. We're also worried about fluid issues, and we have to take some significant steps to deal with these things. All right, so treatment wise, how are we going to handle these burns?
You can start them on lactated ringers.
Okay, so if we're dealing with burns, the fluid replacement we'll prefer is the lactated ringers.
Would you want to like wet some gauze and put all over it what you can to cover it?
Which level are we talking about here?
I was figuring any of them, but
Not
Level
any
3.
of them. Not any of them.
That's third degree.
Nope. That's going to be your partial thickness, second degree. You can use some moist dressings to cover and separate. If you're dealing with fingers and toes, you need to separate those. So you can put the dressings like moist gauze in between them so they don't stick together. That'll be your partial thickness second degree stuff. The full thickness third degree stuff, we're going to use dry, sterile dressings. Nothing wet. We want to make it sterile because we've got a real infection issue potentially coming. So with your full thickness third degree burns, dry, sterile dressings. So first degree, you can do cool water. Second degree, moist dressings. Third degree, dry, sterile. When we're doing fluid replacement, we prefer lactated ringers here. So hopefully you guys are doing that. Make sure that you don't muscle memory automatically pick normal saline. You wanna go for the lactated ringers here. And then when we're starting to base our transport decision and make this treatment thing all, we've got to determine a percentage of body surface area that's burned. So you guys all know about the rule of nines. The book's got a nice chart for adults and children for the rule of nines. So you should be familiar with that. I feel like there's probably going to be some questions coming your way soon about how that, determining the percentages for folks. There's also a rule of palm. And so it would be, this is in reference to the patient, not your palm, but the patient's palm. So if you take the patient's palm and cover the area, their palm represents 1%. So if you can visualize how big the palm of their hand is, and visualize the affected area, what their palm would cover is 1%. Is an estimation for you. Again, that's their palm, not yours. So different in smaller people for us. So let's talk about managing these folks. First degree burns, not an issue, right? We don't need fluid replacement. We're probably just going to be dealing with some flushing, rinsing. They're probably going to have some pain of some sort, but it won't be severe. Shouldn't have any like vital sign changes too much and that sort of thing. So first degree, not so much a problem. Second and third degree burns, we're going to get into issues with the skin. This is where things are going to start coming apart. We're going to have some issues with wounds, so we need to be working on wound care to some extent. We're probably going to be working on fluid replacement, which is going to get us into this lactated ringers flowing. And then we're got to figure out where we're going to take these folks. Fluid replacement, there is a formula. You guys familiar with the Parkland formula? There's a formula for determining how much fluid these people need in the burns situation. So with the Parkland formula, this gives you a calculation so you can know how much fluid to give these folks when they have these significant burns. So the formula is more complicated than it used to be, because it used to be a set number and now it's a range. But what they give you is, for the adults, this formula is 2 to 4 mLs times the body weight of the patient in kilograms times the percent of body surface area burned. And that'll be for second and third degrees only. So you'll have to calculate this. And what this calculation is how much, when you multiply those three things together, that's how much fluid these patients should receive in the first 24 hours after the burn. And the way that this fluid is administered is they're going to get half of it in the first 8 hours, and then they'll get the other half over the next 16 hours. Does everybody understand that? Does that make sense to them?
Yeah.
All right.
What were the three things again?
It's the formula is 2 to 4 mLs times the body weight in kilograms times the percent of body surface area burned.
How do you determine if you're going to go with the 2 or 4 mLs in your formula?
I really don't know, because that's what changed in this formula. For the last couple of years, they changed that from, it used to be a standard.
It used to be just 4, right?
Yep, it was a standard 4 mLs times the other two things, and now they're giving you that range of 2 to 4, which basically you can do it with the 4, or you can cut it down to 2, so that's gonna drop that much in half. But I really don't know what their reasoning is behind that. I haven't found anybody that can explain that to me yet, and I don't know how that's going to affect you and your decision to, do I do 2, do I do 3, do I do 4? I don't know. I would, I'm in the mindset of 4 because that's what it's always been. So this little range here is new. But with the children, their range is 3 to 4, and with the adults it's 2 to 4. But before it was always just 4. So
since 4 is still in the range, it would be justifiable and safe just to go with 4 mLs, right?
yeah, that's what I say, because that way I don't have to learn anything different. I don't have to change my way of thinking. So I'm probably still going to just use 4. But I know that I can drop it down a little bit if I need to. And I don't know if it, you got to look at your patients. size versus maybe lung sounds versus those types of things to, if they have fluid in their lungs, maybe you want to do 2 instead of 4. But that's the only thing I can think of. So this is your formula. This is going to determine how much fluid they need over the first 24 hours to help with that fluid shift, to help with that loss of fluid from the burn and replacing it. When you start this calculation, it's going to look like a really, in some cases, it's going to look like a really big number. But when you get it down to the point of like mLs per minute, it's going to be probably a manageable number for you to set your drip rate at. So don't, when you first calculate this thing, don't freak out, and certainly don't say, well, I'm just going to run it wide open, because there's most likely, as we break this down and I'll show you, it'll be something that's manageable for you. So let's do a little sample. If you have a 180-pound patient that has, we'll say, second-degree burns on 40% of their body, you guys try that calculation and see. Let's figure out where we can be with this.
What was the percentage you said, Cliff?
40%, 180 pounds, 40%. And we'll do this Parkland formula and figure out what our fluid's going to look like.
I don't know if I'm right, but I got 218 milliliters per hour.
All right, so you broke it down way far. So let's look at this let's go all the way through this thing here. So
Is that
first,
right?
I don't know, we'll see. Hold on tight. We'll walk through this and see if you're right. The first thing we need to do is work on the body weight. So 180 pounds, how many kilograms?
82 kilograms.
Okay, he went with 82. I'm okay as low as 80 if you want to do 80 and make life easy for yourself on the numbers. 82 is fine. If you're using a calculator, it's probably easy. So we're gonna, what did you use in the 2 to 4 range there, Brian?
4.
He went with 4. So 82 times 4 times 40%. So what was that number? That should have been up around what, 12,000 or something, 12, 13,000?
13,120.
Yeah. So 13,120. That's how many mLs this person's going to get over the first 24 hours. So that's 13 liters of fluid over the first 24 hours. That's what they're going to get. So half of that they're going to get in the first 8, and the other half they're going to get over the next 16. So with the first 8, they're going to get what, 65, 6,600? What's half of that 13,000 number, Brian? Hello? Did everybody go away? Brian went away. All right. Who else is there?
It should be 6,560.
60.
6,560. So that's what they're going to get in the first 8 hours. So let's divide that number by 8.
820.
So 820 is what they're
Hold
going
on,
to get.
Cliff. I had lost you. Do
I
what
know
now?
you ducked out. So Brian, you were at that 13,000 whatever number.
Yeah.
Okay, so that's over the first 24 hours. So they're going to get half of that in the first 8 and the other half over the next 16. So divide that number in half.
All right, working on it.
Divide that by 2, and you should be 6,600.
Divided by 2. Yep, 65, 60.
6560. So that's what they're getting in the first 8 hours. All right. So this is from the time the burn happens, the first 8 hours, 6560. If you divide that 6560 by 8, you get what?
820.
820. That's how many mLs per hour that this patient is going to need. So divide that by 60.
13.6.
13.6 mLs per minute.
Per minute. Oh yeah, I was way off.
Right? So 13.6 mLs per minute. If you're using a 10 drop set, it's 10 drops equals 1 ml. And if we're looking at 13.6, that's 136 drops per minute that they would need. That's a manageable drip for you, and it's probably not wide open, although it may be close. But 800 mLs per hour, that's less than 1 liter per hour. So that's not a wide open drip, because we can run in, if we got a good size IV, we could run in 500 in 10 or 15 minutes. So you guys are going to have to dial these things down and figure this out. But that's what I wanted you to see. It sounds like a big number, because 13 liters in 24 hours is a lot of freaking fluid. But on a small scale, number one, we're not going to have them for that long, so we're never going to see that much fluid run in these people. We're going to see, probably the first hour or less, and we're going to be dealing with maybe about a liter, which is not, a big deal for us. Okay, does that make sense to you guys?
Yep.
Yep.
Mhm.
All right. So we have to determine, with these burn patients, we have to determine the degree of burn, and there may be parts of their body that have different degrees of burn. So they could have one part of their body that has like full thickness 3rd degree burns, while other parts of their body may have 2nd or 1st degree. So we'll have to differentiate between those. Determine the degrees of burn on the body, determine the percentage of body surface area burned, and then determine how we're going to treat them, how much fluid do they need with this Parkland formula. We can get the fluid running, and then we can pass that information along whenever we get them to wherever they're going, be it the local hospitals, or the helicopter crew that picks them up, or the burn center that we drove them to. So it just depends on that capability that we have, because potentially the Gates County area and the Pasquotank and Currituck areas if you're working in any of those, you could have the potential to drive straight to the burn center, right, Natasha and Zach?
Yep.
Yep.
Yeah.
Yeah, because y'all can
Here.
y'all could take them up to Norfolk, right to the burn center, right?
Yep.
Yep. So so this will be good for you. If you're doing that, you need to have these things in place so that when you do your patient pass on to those facility folks, you've estimated a body weight, you've estimated a body surface area percentage burned, you've estimated the degrees of burn, you've calculated the amount of fluid they need with the Parkland formula, and then you'll pass on how much fluid you've administered at that point so that they can pick up from there and they'll move on. And they may tweak those numbers a bit because they'll weigh the patients and get a different weight. They could look at the patients and come up with different percentages and different degrees and that sort of thing. A lot of this is perception to some extent, but we just need a little starting point. So, you know, if you come up with this 180-pound patient with 40% body surface area burn, second degree, then you have a starting point to say, hey, this patient needs 13 liters of fluid over the first 24 hours. And we've started at this rate administering because we've done this calculation. And that's what you need to do. The next thing is determining where we're going to take them. So how do we determine the destination for these burn patients? What is going to change your mind from Albemarle or Chowan or OBX to a burn center?
The significance of the burns and the percentage of body burn.
Okay, so what are they? What percentage are you looking for, Zach, and what significance are you looking for?
So I'm going to say over 40% of second degree or higher.
Yeah, that's what I'm thinking. Something like that.
Something like that?
I'm gonna look up our burn protocol real quick.
All right, let's do that. Let's see what you guys are thinking that could get you into a burn center. So you said 40% second degree or higher. Anything else? Anybody have anything else they want to use?
I'd say 60.
60%. What else?
Wouldn't the area of the body affect the decision also? I mean, 20% of the abdomen and the chest compared to 20% of the legs.
Okay, so she's looking at where it is on the body.
I mean, 10% of the face would automatically tell me go burn center. That's pretty crappy of a burn right there.
She said
All
10%.
right, I've got Pasco tanks pulled up.
Okay, what do they say?
It says critical or serious burns is greater than 5 to 15% of total surface body area. Second or third degree burns or third degree burns greater than 5% for any age group. Required direct transport to burn center. Local facilities should only be utilized if distance to burn center is excessive or critical interventions such as airway management are not available in the field.
Okay. So one of the things you guys should be thinking about with these burn patients is airway management. If their airway receives any kind of burn, inhalation of smoke, inhalation of toxic gases, carbon monoxide are things that we need to be checking for. So if you have a monitor or monitoring capability to measure carbon monoxide, if you bought that feature for your monitor, that Massimo rainbow feature thing that can measure carbon monoxide, that'd be a good thing to put on. And see about that. If we're looking inside of their nose or mouth and we're seeing soot, if we're seeing burn things, airway management is probably going to become challenging because we're going to expect things to start swelling. We've got the trauma of the burn. We know the fluid shift is coming. There could be some swelling. So watch out for airway management. If there is an inhalation burn, that's criteria for a burn center. Partial thickness burn greater than 10% will get you to a burn center. Any full thickness burn will get you to a burn center. Burns on the hands, feet, face, genitals, that will get you to a burn center. Electrical burns, including lightning strikes, burn center. Chemical burns, and then patients that have burns with pre-existing medical conditions that the burns could cause problems for. Those are types of things that you can justify sending your patient to a burn center. That's a table in your book. If you've got your book, table 35-7 is some criteria that you can get. You can justify sending your patient to a burn center. So those are some things to do it. So you guys are thinking along the right lines. She said 10% to the face. Any burns to the face, feet, hands, genitals, send them to the burn center. If they've been struck by lightning, they need to go. If their airway is burned, they need to go. Significant burns, which is greater than 10% partial thickness or any full thickness, they should go. You guys good with that?
Yep.
All right.
Yeah.
Remember with electrical burns, the electricity entering the body is looking for ground when it gets in the body. And when it comes out to find ground, there could be exit wounds. So people that are struck by lightning, they could have exit wounds from where that lightning comes out of their body looking for ground. Same with electricity. If they've touched electrical wires or electrical appliances and they're getting shocked, they could have some exit wounds. There's a picture in your book 35-29 that shows that, and you can see what those exit wounds kind of look like. Those are minor ones in the picture. Looks like the forearm and the hand is where they come out. So you'll see them in different places. A lot of the lightning strike folks, they have those exit wounds. They kind of like blow out in the elbows, the knees, the feet, maybe their butt. The biggest problem with electrical burns, other than the injuries, the physical injuries, is the possibility of cardiac dysrhythmias. So if you're dealing with electrical burns, you want to make sure that you're doing 12 leads on these folks, okay? Just so you can see. And then you've got the scene safety of electricity. So don't go touching people that are being shocked unless you want to be shocked.
You can always whack them with a stick and get them off there.
Yeah, something that's non-electrically conducting, wood, fiberglass, those types of things, you can kind of knock them off or try to. Securing the power is the best way to operate. So kill the power source, and that stops everything. But if you're having a hard time finding it, again, be careful. Electricity has the ability to jump in high voltage cases. So if there's like a power line wire on the ground, because of let's say a vehicle accident knocked over a power line pole and the wires are on the ground, you do not have to physically come in contact with that wire to get shocked by it. You can just get close to it, and that electricity will jump over and get you. So this is why when we're managing scenes and talking about scene safety, do not jump over or step over electrical wires on the ground. These high voltage power lines, supply wires, don't step over them. Don't stand close to them, because if they're still energized, that stuff can jump over and grab you. You don't have to physically touch it. So keep some distance between you and them until you're absolutely certain that that stuff is not energized anymore. All right, so this is why we get the power line, the power companies involved. We get them shutting down systems and grids and circuits and those types of things. That's why if people are in their vehicles, tell them to stay in their vehicles, because if they're not being shocked in their vehicles, they're safe. As soon as they get out, they open that door and put their foot on the ground, things could change quickly. So be mindful of those things. If you're dealing with chemical burns, just remember water is not always the answer. It depends on the chemical. So if you're not sure how to deal with that chemical, if you have the ability to get your hands on the SDS, do so, and it should give you some information about it. You can always contact Poison Control, and they can help you out with it. If it is a hazmat type of chemical, you can call Chemtrek. They can help you out with it. So you use those resources if there's any question. But it would be terrible if you started spraying water on somebody and because they have a chemical burn and you make it worse. So remember that some chemicals react with water, and it could become very bad. Any questions about burns?
Nope.
All right, so you'll see some more on that coming up this week. All right, so chapter 36 is going to give us musculoskeletal injuries. So again, at the beginning of the chapter, you're going to get a little anatomy and physiology. So 206 bones in the body. We'll just take turns going around. Everybody can name them until we get them all named. Brian, you can go first.
Cliff's big head.
So that there's 206 bones in the body. There's more than 700 muscles. I don't expect anybody to know the 700 muscles and be able to name the 206 bones. But I will tell you, the more you know about them, the better off you're going to be. And you should at least know the large ones and the significant ones that we're going to be dealing with. If you don't have the distinction in your mind between ligaments and tendons, remember that ligaments connect bone to bone and tendons connect muscle to bone. So that's their jobs. Try to sort that out in your mind. If you're not there yet, cartilage is between the bones. That's the cushion between them. That does wear down over time and use. That's why people are getting knee replacements and hip replacements and those types of things. As that cartilage wears out, then the bones are rubbing against each other, quite painful. That sort of thing. So, with musculoskeletal injuries, we are talking about broken bones, fractured bones, sprains, strains, those types of things. And again, these fractured bones, they come in two categories. They can be open or closed. If they are closed, that means there's no damage to the skin and there's a broken bone. If it's open, the broken bone is poking out of the skin, so it has punctured the skin, and there's an opening in the skin, which is why we call it an open fracture. So we have closed fractures, open fractures, and that sort of thing. Most of our treatments in this category, in this chapter, are going to be splinting and immobilizing. The extremities, if we're looking at musculoskeletal injuries in the arms or legs, we're going to be splinting and immobilizing. And then musculoskeletal injuries in the other parts of the body, if we're looking at the spine, the ribs, the neck, those places, and the head, then it's going to be more not splinting, but just immobilizing. From our assessment standpoint, we want to make sure the first thing that we do with these injuries before we start doing the splinting or immobilizing is checking for pulse, motor, sensory functions distal to the injury. So in every case, when you're dealing with these things, pulse, motor function, sensory function distal to the injury, check that before you start doing anything, and then recheck it after you're finished with your splinting or immobilizing. Those are going to be the keys. That's going to be what your evaluators are going to be looking for when you're doing your TSOPs. So make sure that you're going to do that in every case before and after you have to do any immobilizing or splinting. And that's going to be one of those critical failure type of things if you skip over that. These two chapters, the soft tissue injuries, the burns, and the musculoskeletal injuries, in our trauma assessment, this is where that mnemonic DCAP BTLS comes from. So all of these injuries fall into that DCAP BTLS realm. So let's make sure somebody want to take that and tell us what it is, the DCAP BTLS. Let's make sure everybody knows what they're looking for.
Deformities.
Yep.
Crepitus.
Contusions,
Contusions.
abrasions,
Yep.
penetrations,
Yep.
burns, tenderness, lacerations, and swelling.
There you go. Deformities, contusions, abrasions, penetrating injuries or punctures, burns, tenderness, lacerations, and swelling. Those are the things we're looking for with these two chapters, with these three areas. That's what we're looking for. So as we're doing this trauma assessment, we do our rapid trauma assessment, which is checking for ABCs and life threats. Life threats being excessive bleeding, uncontrolled, things of that nature. And then once we get that taken care of and we come back for that more focused, detailed exam, when we're doing that focused, detailed exam, these are the things that we're looking for. This DCAP BTLS stuff. So we're looking for all of these injuries. We're going to note those as we're going down the body. And if they need attention, these are the things that we're going to treat. The punctures or the penetrating injuries, if they're in the chest or abdomen, these are the ones that are getting those occlusive dressings and bleeding control. If they're in the extremities, it's going to be bleeding control. And if we can't get it with direct pressure, we'll be putting tourniquets on, that type of thing. The burns we talked extensively about. So we're going to note those by degree, by body surface area percentage, and then the treatments are going to come in accordingly with wound care, with fluid replacement, those types of things. So we need to do a good assessment, find all of these issues, and then treat them appropriately. In most trauma cases, we have to expose the skin to see these things. So make sure that you guys are doing that. In a lot of cases, the clothes have to come off. You got to get down to the skin, and you can't do that. You won't find all of the things if you don't take the clothes off. So make sure you're doing that, and you can get to everything, see everything you need to see. There's nothing worse for the EMS people than to take a patient into an ER that's been in a traumatic injury and you haven't exposed their skin. And when the ER starts cutting clothes off because you didn't, they start finding all these problems. That's a bad day. All right. We have traction splints. Traction splints treat what kind of injuries?
Femur fractures.
What kind of femur fractures?
Closed.
Closed femur fractures. If it's an open femur fracture, how do you treat it?
Put a marky mark and just jam it back in there like Lone
No.
Survivor.
No, stop talking.
Pack it with dirt.
Nope. Yeah, I know. Spit tobacco juice on it, right? Yeah, it fixes everything. What do we do with the open femur
Just
fracture?
immobilize it.
Yes, just immobilize it with a rigid splint of some sort. No traction on the open femur fractures, because if we put traction on it, we do have the tendency, we will pull that bone back inside. It could create more issues, cause more problems, do more damage. So if it's closed, we can pull traction. If it's open, we don't. We'll just splint it as it is. All of your other injuries, we're going to splint them in some form or fashion. But remember the key: checking distal pulses, sensory and motor functions before and after. All right. Your book discusses all the different types of fractures, transverse, spiral, green stick, impacted, comminuted. You're going to have to read to get the differences on those. Is it going to matter for us in our treatments? Most likely not. The only thing that's going to matter for our treatments basically is going to be open versus closed. Everything else, everything's going to fall into one of those two categories, and that's how we're going to deal with it. Those things are going to matter for long-term care and how they get those fixed, whether it's just a rigid splint or a hard cast, or if they need surgery with pins and screws and plates and all that jazz. So keep that stuff in mind. Your book does talk about mass trousers. It gives you a picture of them. These are the pneumatic anti-shock garments. Nobody carries these things on the trucks anymore. I'm not even sure you could find them if you wanted to. So read up on them. in your book, and talk about them. Since it's in the book, there is the possibility that there's test questions related to them. They haven't taken them out of the curriculum yet, even though everybody has taken them off the trucks. So just read about the pneumatic anti-shark garment. We called them mask trousers when we had them. Read about them, how to inflate them, what the purposes are, that sort of thing, and be familiar with that, but you won't use them.
Did you ever use any, Cliff?
No, I mean, when I started in this world, they were still on the trucks, but I've never put them on anybody. And then it wasn't long after they took them off. The state stopped requiring them, so they took them off the trucks because as soon as the state stops requiring something, everybody takes them off as fast as they can, and so they've been off for years now. But I don't know why. On a national level, somewhere somebody's using them because they're still in the curriculum. That's Brian's philosophy, and it's got to have some truth to it. So somewhere in this country, they're using mask trousers. That's all I know. But we won't dive into them too much because nobody's going to use them here. But you do need to be familiar with them, just in case your module exam has some test questions on it. But that would be it. Anybody have any questions about these 2 chapters?
I'm good.
Nope.
No.
No.
So this is splinting, immobilizing, bleeding control, wound care, and treatment of burns. Those are going to be the skill type of things that you're going to be doing in your labs this week. So you'll get some hands-on with the splinting and immobilizing. We'll work some more with that Parkland formula as far as dealing with burns and that sort of thing. Show you some burn bandaging treatments, and then bleeding control, tourniquet use, and shock management. All right. So fun times coming in the labs. If you haven't picked a lab for this week, shame on you. So we'll see.
I'm not going to make the lab this week, Cliff.
Yeah, I figured you wouldn't. I understand. That's fine. It's a 3-hour lab this week. So if you're going to Elizabeth City, it starts at 9. If you are in Perquimans, it starts at 6. So those are the things we'll be working on. If anybody wanted to retest their Module 5 exam, I will say, remember we said that's the biggest bite you got in this course. Everybody did fairly well. But you do have the ability and the privilege to retest within 7 days. So by Thursday this week, it needs to be done. So you can do that. If you're going Wednesday night, there is I think there's 1 or 2 people that are scheduled to retest. They're going to be there about an hour early before the lab starts. If you'd like to join in on that, let me know so that we can have enough test copies available. And if you're good, then we'll keep cruising. Like I said, from here it's downhill. A couple more module exams, and we'll be looking at TSOPs in the final. All right.
Cool deal.
All right.
Sounds good.
Hey, Cliff. So I did just email Cameron a little while ago.
Okay.
2 days in March, and I think I'm going to pick 2 more days in April.
Okay.
And she did acknowledge the email, so she did get it.
Okay. She'll get it scheduled, and she should let you know that you're good to go with those days and times that you picked. Everybody else, when you're due to ride, make sure you're showing up to ride. If for whatever reason you cannot be there, send Cameron an email as soon as possible so that she can inform the the agency that you will not be making it, and then you'll need to reschedule time if that's what you have to do. So make sure you send her some alternate days if something comes up and you can't get there. All right. Anything else before we cut out of here? We're finished a little early, but